Welcome, everyone. On behalf of Centers for Medicare and Medicaid Service, CMS Divisions of Tribal Affairs, in collaboration with the CMS Centers for Clinical Standards and Quality, I'd like to welcome everyone to an All Tribes webinar. My name is Michaela Holm. I work with Kaufman and Associates, and I'll be your moderator today. Today's webinar is titled CMS Quality Improvement Assistance to AI/AN Communities Listening Session. This webinar series is supported by an award by Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Services. With that being said, I'd like to welcome everyone to today's webinar, and I'll pass it over to Beverly. Thank you.
Thank you so much, Michaela. Hi, I'm Beverly Lofton. I'm a senior policy advisor at the Division of Tribal Affairs with CMS. So welcome to today's webinar. And as Michaela mentioned earlier, this webinar is in collaboration with the Division of Tribal Affairs at CMS and the CMS Center for Clinical Standards and Quality Improvement. I hope I got that right. It's CCSQ. During this webinar, our presenters will discuss CMS, how CMS is re-envisioning quality improvement efforts for the American Indian and Alaska Natives Healthcare Quality Initiative through a community-centered lens. Any materials related to this presentation can be downloaded from the Spotlight page of the CMS American Indian and Alaska Natives Outreach and Education website, and that can be found at go.cms.gov/AIAN. The web link will be added to this chat. So we are pleased to be joined on this webinar by Allison McCoy and her colleagues, and they are located in CMS Quality Improvement and Innovation Group. So at this point, I will hand this presentation over to Allison to introduce her colleagues, and we can start the presentation. Thank you.
Thank you so much, Beverly, and hello. I'm Allie McCoy. I am the brand new Division Director for the Division of Quality Improvement and Innovation Models Testing over at CMS. That team oversees the American Indian and Alaska Natives Quality Improvement work. You'll have to forgive me. Today's my first day back after, unfortunately, contracting COVID. And I certainly look like I am still recovering from COVID, even though I feel much better. So apologies for not having my camera on today, but I'm very excited to be with you today. And I'm so excited to be a part of this work. I previously worked with the QIO programs at CMS when I came to the organization in 2017, but I've spent the last few years working in our Office of Program Operations and Local Engagement. And I'm very excited to be back with the QIO programs. And to get back to work with this team on the exciting work ahead. So our CMS QUIG Group Director, Anita Montero, would have been on the call with us today, but she is in the air presently. That being said, she did want me to convey a couple of key points to this group. The CMS team recently had the privilege to meet with tribal leadership at the beginning of this month, including a listening session that our Chief Operating Officer, John Blum, and the Director of the Office of Minority Health at CMS, LaShawn McIver, was able to attend. Through these recent visits and listening sessions, as well as many lessons learned from our previous and current work, we've identified several opportunities for our future work. One, we've identified that we've tried to approach this work from a community-based standpoint, looking at where the population we serve works, plays, seeks healthcare, et cetera. But that being said, we'd like to further refine the community-based approach moving forward and refine it geographically to have an approach that works to best reflect the geographic communities as well. Two, we'd like to spend time meeting with our stakeholders and meeting them where they're at, really getting to know and assess their needs and their desires for the work. And finally, we'd like to recognize and understand the differences in cultural approaches, both to this work and to healthcare in general, and better understand that. So to summarize, our hope is to co-design the future work focusing on the needs of the AI/AN communities based on the feedback that we receive and the continued partnerships that we hope to have. And with that, I'm going to pass the presentation over to my colleague, Tim Watson, from our team to introduce himself and to talk further about this important work. Tim?
Thank you, Allie. Appreciate it. My name is Tim Watson, and I have been with CMS for a long time, but I gotta say this is the most rewarding work that I've worked on probably in my whole time here. What we are doing is we are trying to assist the communities in their approach to quality improvement with healthcare. And I think let's go to the next slide. That actually will help set it up. Okay. Traditionally, the quality improvement program within CMS has been around for many decades. But to be honest with you, we haven't done as much as we should, if anything, to tailor our approach for your communities, and to integrate your cultures and so forth into our work. We've done good work along the way, but it's not good enough. So we're going to change the way that we approach quality improvement. What we have traditionally done and will continue to do is provide direct technical assistance to facilities with healthcare quality and safety needs. But one of the things we've recognized is we are not the solution. We are not the we don't have the knowledge base to come in and tell anybody what to do. Okay, we need you. You all are the solution. You all know your communities. You all really know what has to happen. And what we want to do is we want to collaborate, we want to help, we want to support. And so what I'd like to talk about here for a minute is what we're currently doing in our current work, which is some pretty good, really good work. I'm proud of it. But then we need your help to help us frame what we're going to do ongoing, and pull from you what you would like to see us do. And I want to say up front before we could go to the next slide, but I do want to say up front, I'm the type that let's not have any boundaries here. You never know if you can do something unless you ask. And so, you know, it's too easy sometimes just to say, oh no, we can't do that, or this, that, and the other. We want everything on the table. We want to think about it. And we want to see what we can do. Okay, let's talk about our current work. Currently, we do have, and I said previously, we haven't tailored our work enough to the AIN communities. I'm not saying we haven't at all. We have. We've been building on it, and we've been doing so for about, I'd say 6 or 7 years. I'm saying we just need to do it better and more. Okay, so currently under our current program, what we're doing, and this ends in 2024, I think it's the end of September 2024. We have 2 initiatives within our group that work with AIN communities. The one that I primarily have been working with is the one in the yellow box on that left-hand side. It's the American Indian Alaska Native Healthcare Quality Initiative. You all may have heard of it, called PATH. It involves 24 Medicare certified IHS facilities, and we have 1 contractor. At this point, it's Comagin, that is working with all 24 of those facilities on various things, which are on the bottom of the slide: patient safety, quality improvement, care transitions, public health emergency came in handy during COVID. Substance abuse misuse is really opioid related, and so forth. On the blue box is our hospital quality improvement contractors. Now that group also, we opened it up for all tribally run or managed hospitals were eligible to join it if they chose to. And I have that number somewhere. Many did, but to put it in perspective, that's about 2,000 hospitals. And so the tribally run facilities, the 638s that came into that group, are a relatively small part of the overall group. We have tried to make sure that we focused on the specific needs of the AIAN facilities, but you know, being part of a group of 2,000 other hospitals, rural and critical access hospitals, probably not as focused as it should be. Okay, let's go to the next slide. Staying in the area of what we're currently doing, because in a minute I'm going to move to what we would like to do and where we're going. Some of the things we've worked on, particularly in the PATH program or the AIAN HQI, we've helped with accreditation and survey support. I think these numbers are, well, I know these numbers that are on that slide are a little bit, they've changed. It said that, it says there that there was improvement with 9 of 19 hospitals achieving PCMH certification or recertification. I think that number is greater than that. I also want to point out that 9 of 19 doesn't mean the other 10 didn't do it. It just meant they were still in process. We've not had anybody working with us not pass that accreditation. I do want to be really clear on that. We are not acting in our capacity. We are not the accreditation agency. We don't do the survey and certification part. We aren't going in and doing any audits or anything like that. And there's a very clear line between us and those that do. We are quality improvement. And so our role in that is we bring resources, we bring people. It's voluntary and no cost to come in and prepare for those types of things. We have people that know about, have the resources and so forth. But it's to prepare. It's not part of a survey or anything like that. That's a whole different world. And you know, and it's not just CMS certification. We help with all sorts of certification. It just all wraps into you know, like JCO or not JCO. Yeah, Joint Commission and so forth. It just wraps into what we do from a quality improvement perspective. Okay, the 29 on-demand training videos, that happens to be the ones that we've currently worked on. There's more. That's a capacity that could be expanded as need be. I will say one thing we're really, and you can see the categories there: leading improvement, QAPI basics, which we'll talk about in a minute, just culture, emergency department dashboards, opioid stewardship, things like that. Those are examples. We're really trying to focus on how to make things really, really concise, really as simple as possible, because we're recognizing that one thing I forgot to do at the beginning of this presentation, folks' time is really important, and carving an hour or something like that out of a day is really difficult to do when you're busy and you've got 1,000 things to do. And so what I should have done at the top is thank you so much for your time. I know what it means. So we're kind of focusing on little micro learning sessions and things like that. But we also combine that with, you know, the micro learning sessions can help you in so many ways, and I'll talk about that again in a minute, but also one-on-one support, a place to call, a face to talk to. Just we really want to help in any way we can. And I know there are some limitations, but really we try to do as much as we can up to that point. So one of the other things we've done is support and training for the CDC's National Health and Safety Network. Now this NHSN, this was specifically something that IHS requested and wanted. It was a priority for them, and I know they're asking that reporting be done instead of quarterly, I think monthly. And in that time, they've raised the reporting incidents from 50% to 100%. And I'm going to circle back to that in a minute after readmissions. Readmissions, we're working with large census hospitals there, and well, and low census, but we work at different, we separate them out. But we had a 6% relative improvement rate on readmissions and an 8% relative improvement rate on readmissions for low census hospitals. I want to point out on all of this, the readmissions and the NHSN and really everything, we didn't do it. We supported, we brought resources to the table and so forth, but nothing, the facilities did it. We're coming in to collaborate and support and try to help. But any successes, I really don't view as our successes. It's what you all are doing. And that's the approach we intend to take and will take. Let's go to the next slide real quick. Okay, a little more, some of the things that we're talking about, and I just talked about certification and accreditation and probably went more into it than I should have at the time. But our folks, our contractors that we use, they are there to help support any of those readiness activities. I just got feedback from, and I'm not going to say which area because I'm not sure if they'd want me to or not, but we had one of our quality improvement advisors on site at a recent facility that was preparing for certification. And so they were going through mock surveys, and they were putting together some of the documentation and so forth. And I got an unsolicited, on a call we were on, an unsolicited thank you that quality improvement advisor went way above and beyond what the facility thought was possible or what they could do. And literally our quality improvement advisor was on site with the facility, helping to prepare them for when the surveyors came in. We've gotten a lot of feedback that goes really well, but I'm not sure we've done a real good job of promoting that it's there. So anyway, that's one example. That next circle talks about some of the tools that have been developed so that the facilities can do their own self-assessments, one-on-one coaching, and so forth. The third circle talks about we're in a changing world. There's always new regs. Regs is probably the wrong word, but new rules, new standards, new just new things happening, new information coming out, and so forth. And we view that as, we not everybody has time every day when your primary goal is to treat patients. We want our contractors, and they do, to be experts in that area and know what's coming down the chart, or down the path, know what's important, sort of know how to work with it, and boil it down to easily translate that to anyone working with them. So I think they're pretty good at it. And I don't think in the next few years anything's going to change in terms of there's always something new coming down the path, and keeping track of it is difficult. So we can help be that resource as well. That next circle talks about, and we're going to expand on this in a second. Staff turnover is an issue. But not just staff turnover and retention and so forth, but also limited staff that are doing too many things. And I don't mean that in a bad way. I just mean, that if you have so many duties, sometimes it's hard to, you focus on what you need to at the time. And so we're trying to help with that in a lot of ways. Some of which are, with staff onboarding, we can help with some of the training or tools, or we're even at some point the stopgap knowledge, so you don't lose knowledge. And so, and I'm not doing it justice. So much falls into that area that we can do. Let's go to the next slide. Okay, this is one of our contractors. It's the one that works. It's PATH. It's the one that works with PATH. They have a few other subcontractors we don't need to talk about, but it's a single site. That website, and you could just go to comagin.org, and it would get you into it. But okay, on this website, you can see some of the areas that they've put together resources. And I'm not asking you to click into it right now, but the PATH home page gives you actually phone numbers and humans to get through and talk to. On this page, this is some of the resources, and the PATH on demand training are in these resources. So if we can go down and click on QAPI. Okay. Underneath QAPI, and again, I want to be clear, this isn't something where we're saying, oh, okay, you need help, here's the website. No, the website's just one tool. Okay. But on this, if you look at that top section, you've got the QAPI review worksheet, you got the QAPI program toolkit, you got the checklist, and so forth. Those are all really good tools that can help you with QAPI programs. If you're like me, and being in the government, we love our acronyms. You might be saying, what's QAPI? Some of you, of course, you know it. I didn't. So underneath, when you see the on-demand training, there's a whole bunch of videos, and we went to wanting things in bite-sized chunks, 2, 3, 4 minutes. Who has time to sit through an hour and a half webinar on a Wednesday where you know, and we still do some of that, and that's fine, it's useful. But in this case, if you have somebody new, or they somebody just charged with working on a QAPI program or whatever, it's a place to start. And so what I'd like to do, if you'll indulge me, is look at the 2-minute, 12-second, just what is QAPI, so you know what I'm talking about.
Welcome to PATH QAPI Basics. Today we answer the question, what is QAPI? Working in the healthcare world often means understanding a lot of acronyms. You may have heard the term QAPI related to your organization's quality program and activities. QAPI is the merger of two complementary approaches to quality management, quality assessment and assurance, QA, and performance improvement, PI. Both are integral parts of quality management and use data to identify problems, but they differ in key ways. QA, which also includes quality control practices, is a process of meeting quality standards and assuring that care reaches an acceptable level through inspection. Healthcare facilities typically set QA thresholds to comply with regulations or external quality reporting programs. QA is a reactive, retrospective effort to examine why a facility failed to meet certain standards. QA activities do improve quality, but efforts frequently end once the standard is met. PI, sometimes also called quality improvement or continuous improvement, is a proactive and continuous study of processes with the intent to prevent or decrease the likelihood of problems. PI identifies areas of opportunity and tests new approaches to fix underlying causes of persistent, systemic problems. PI aims to improve processes involved in healthcare delivery and patient and family experience. PI can make good quality even better. QA and PI combine to form QAPI, a comprehensive, data-driven, and proactive approach to ensuring high-quality care. The activities of QAPI depend on members at all levels of the organization to identify opportunities for improvement, address gaps in systems or processes, develop and implement an improvement or corrective plan, and continuously monitor effectiveness of interventions. For more information, find PATH on comagin.org or email us at path@comagin.org.
that video is it's really basic, but if somebody doesn't know where to start, or it's a good introduction, and then the other videos take you deeper if you like. And then the tools are there to work on it. And that's just one example of a lot of what we do. Another example, this particular slide talks about opioid adverse event prevention. And again, this is another example of where it's not really us or our project, and we're not taking credit for this project, but the IHS has an excellent what they call their HOPE committee, heroin, opioids, and pain efforts, and they're doing great work. And we don't want to come in and change anything or put our stamp on it and say, no, it's got to be this way, or so forth. We want to support, we want to collaborate, we want to help where we can. And so in this case, our contractors started meeting with some of the folks from the HOPE committee to try to figure out where they could fit in and where they could help. And so they helped work on developing a communication toolkit for co-prescribing and so forth. And this talks more about the kit and the posters that are being shared and the conversation starters and so forth. And we've gotten really good feedback on it. But I think the most important thing is it's an add-on. It's not instead, and it doesn't drive things. We'll go to the next slide. Okay, now let's switch to what we want to do. That's what we're doing at the moment. And Allie hit it on the head at the beginning of this presentation. We want to change the way we do business even more. We want to come in to any and all communities and spend some time figuring out how we can support, how we can help, how we can collaborate. We don't want to come in and say, hey, this has to happen, so now do this. And our goal is to address the healthcare inequities affecting the AIAN populations. And part of that, we want to do a better job. I use the term better because I'm not sure we've done much in the first place of understanding and working with traditional practices, your traditional practices along with Western medicine. And the big goal or focal point for us is we need to meet where you're at. We need to come into communities and see what your wants and needs are rather than what ours are. Okay, it's not about us. And so we're in the process of putting together our work that will begin in the fall of 2024. It'll be a 5-year program, and then hopefully after that. But where we would actually come in and collaborate with the communities, talk with the community members, tribal leaders, other leaders of various parts of the community, and kind of do an assessment for strengths, needs, and opportunities. And can we go to the next slide? And we're going to expand. In that first slide, I talked about the 24 Medicare managed, or Medicare, IHS managed Medicare facilities. And then we combined the tribally managed facilities, but these were all just hospitals, inpatient for the most part. We want to expand. We want to start to include outpatient facilities for IHS, but we also want to bring the tribally managed, any of those facilities under this umbrella, rather than, for lack of a better word, diluting them in the broader work with all the other hospitals of the country. We just think that we need to focus more on the specific needs for your communities, and then also add Indian health programs. And I would draw another line over in another box and say, who are we forgetting? Who else should we include? And that's one of the questions we have for you. I know already we're thinking skilled nursing facilities or nursing homes, and some other facilities, but we don't know what we don't know. So if there's anyone else we should be thinking, we're all ears. Let's go to the next one. Oh, by the way, those numbers, just so you know, I don't know if they're accurate anymore. They changed a little bit. They're close, but they may be off a little bit. Okay. There's a lot on this slide, and I think this is something that's best sitting with. So I'm not going to go deeply into any of it, but this wheel talks about reducing disparities and improving health equity. And it gives you an idea, some of the things that we have worked on, we can work on, we're thinking of working on. With the most important part to me is the hub on the wheel is the Medicare beneficiaries in your communities. There's a lot there. I don't want to get too much into it, but that might be something just better served looking at later. But it's driving where we're going. Let's go to the next slide. Okay, here's where we're at. And we've got a half hour left, which is good because I wanted to spend more time hearing from you all. Here's some of the questions that we have, and that's why we're coming to you to listen, because I want to be clear. We're still developing this work. We are still trying to figure out exactly where we're going to take it. We've got a pretty good idea, but we can't do it without you, because the solutions to any perceived issues that you have in your communities will come from you, not from us. And so we're not, I'm going to use the word arrogant. We're not arrogant enough to think that we have all the answers or that we even know all the questions. And so even this list of questions, they're suggested questions. I said at the beginning, we don't have any parameters. We don't have any preconceived notion of where, where we need to go. We might be completely missing something. So I'd like to look at these questions and see if you all have any input on them in terms of things we should know, things we should consider, and so forth, but don't limit yourself to anything on here. Really, I would open it up for anything you would like to tell us. And, that's all I have for the moment. And I'd like to just see where we go. And then, I've got more examples of some of the things we have done if we want to share them, but I think I'd like to pause and just open it up.
Michaela, this will be a good time. If you can remind the participants on how they can ask questions through the chat, or through the Q&A function, or if they want to unmute and ask a question. So if you can go through that, that would be great.
Yes, absolutely. So at this time, we're opening up for questions. At the bottom of your screen, you'll see a Q&A box. You can type in your questions there and we'll read them out loud, or you can use the raise hand function and we can unmute your line.
I also want to point out while we're waiting, one flaw in our slide deck that I'm looking at is we need to put contact information. Because even if we don't get the questions here, we will always, you can contact us directly as well, and always willing to talk through things. And even in 2024, when we start the next phase, I don't want this to be static. If 2 years into the program, we need to readjust and do something to better meet your needs, we need to do that. So I view it as a conversation, not just here we are and then we disappear.
Absolutely. Thank you, Tim. And again, if you'd like to use the raise hand function, we can unmute your line, or you can place a question or comment in the Q&A box. So we do have one in the Q&A. So It says that we need greater access to mental health services. I'd also like to caution you in asking too much about traditional medicine. There are many practices that are sacred that won't be shared outside the Indigenous community.
I think that's a fair and really good point that maybe we don't consider enough the part on the traditional medicine. And we certainly wouldn't want to go into any community and try to push things too hard or get pushy or get into where it's not appropriate. So I that's the first time I've heard somebody say that, but it is well taken. It makes sense to me. And we certainly don't want to go into anywhere where we actually do more harm than good or cause any discomfort. The mental health piece, one of the big approaches, and I'd be interested at some point finding out what types of help and how much more, or not even help, just support or resources or whatever we could provide. And so that's someplace we could go. I will say that mental health, behavioral health, and we could roll in opioid and substance abuse and all that kind of good stuff, or good stuff, wrong way to say that, all that sort of things. That is a major focus of ours. And yeah, absolutely. And it's going to look different, just so you all know, it's going to look different for every community. You know, it's not one AIAN community. You're all, every area is different, has different beliefs and cultural differences. And so the way we're actually looking at designing our work is our contractors would come in and look at each community separately and see what the community wants. And in some cases, like for example, I'm not gonna say the areas, but when we were talking mental health on a TTAG call one time, there was one area that says, oh yeah, we really need help with that. There was another one that says, we have a really good facility, we this that and the other, we don't need help with that. So in that case, one region would get the assistance in that area, the other wouldn't. They don't want it. So the very good points.
We have another comment in the Q&A box as well. So we are focusing much efforts on pain management and have been working with Oregon Pain Guidance, OPAT, to develop some group therapy strategies and finding ways to support alternatives to opioid use for chronic pain. OPAT or OPAT is a great resource that might be included in your work. And then I also have the link here that I can put in the chat.
Beautiful, thank you. One thing I didn't mention is my co-lead on this project is Sabrina Chaktura, who has the clinical background that I do not. And so unfortunately, by her not being able to be here today, you're missing her response, because I'm sure she'd be all over that and want to talk about it a little bit more. But absolutely, thank you so much. Appreciate it.
So Beverly and Tim, I'm not seeing anything else come through at this time.
Okay, thank you, Michaela. And thank you so much, Tim. Did you have anything else that you wanted to say in closing before I do our general closing remarks?
No, other than again, I really appreciate your time. I know your time's important, and I'm honored to be even allowed to come speak with you all. To me, it's an honor to do so. I also know it's an awful lot of information. It's an awful lot of, there's a lot to digest and so forth. And so sometimes it's hard in a larger group like this to really get into a conversation deeply about anything. I mean it from the bottom of my heart that we're open. If you would like to discuss anything with us, we really want this next body of work to meet your needs. It is completely voluntary. Nobody has to do anything. And I really believe the only way we can be successful is if we add value for you and we don't add any burden. And that's a hard thing to do sometimes. And I will put my information in the chat, and then maybe we'll want to put mine and Sabrina and so forth if we send something out to the group, so everybody has it. But that's all I have. Thank you so much. I really appreciate it.
Thank you so much, Tim. And thanks again, Michaela. And that's a great point, adding value and not burden. I love that. Thank you. So I would like to thank everyone for your participation in this webinar. And I also want to remind you that a copy of the webinar can be found on our Spotlight page. And that's on the AIAN Outreach and Education website. Again, you can find that at go.cms.gov/AIAN, and that will be found under All Tribes Calls. As always, you can submit any inquiries to the Division of Tribal Affairs at CMS, and our mailbox can be found at tribalaffairs@cms.hhs.gov. And then you'll also see in the chat that Tim has put in his contact information. So he has his phone number and email. His phone number is 816-807-9759. And he can be reached by email at timothy.watson@cms.hhs.gov. Again, that's timothy.watson@cms.hhs.gov. Otherwise, thanks everyone for joining us today and have a great afternoon.